Hi, welcome to a lecture about cervical glandular lesions. My name is Natalie Benign. Today I will discuss the following. This is the outline, so we'll start with normal endocervix, then move on to benign glandular lesions of the cervix, and then adenocarcinoma of the uterine cervix. So we'll start first with normal and reactive endocervical cells. So normal endocervical glands are noted here in an endocervical curettage specimen, which honestly is where practicing pathologists encounter these cells very frequently. You can see basally oriented nuclei with a columnar shape and apically oriented mucin. Reactive forms can also be noted in the endocervical curettage specimens, including nuclear enlargement and focal multinucleation, which you can see in the center of the photo there. Drying artifact is also often present and must be interpreted within the context of other cells within the specimen. These are important changes to note on histologic section, as they can also show up on pap smears. This is a multinucleated endocervical cell, similar to that noted in the curettage specimen. This is a view of normal endocervical glands in a histologic section at the cervical transformation zone with basally oriented nuclei and apical mucinous cytoplasm. In some samples, you can see reactive changes, and in this one, you can see tubal metaplastic change. Another important change to note on histologic section, as it can also show up in pap smears, where it can have some features which would be concerning for a typical change, including overlap and crowding nuclei. But when you notice the cilia there with the yellow arrow at the top, you can explain the presence of those cells. So these are the benign glandular lesions of the uterine cervix as noted in the 2020 WHO, and I will cover the ones that I have highlighted in black here. The others are not so common, and in the interest of time, I'm going to cover the ones that you're more likely to encounter. So we'll start with an endocervical polyp. This is an endocervical polyp. One must take pictures of these at low power, but you can see the general idea is that there's a fibrovascular core covered by benign endocervical epithelium, which can and frequently is involved by squamous metaplastic changes. And keep in mind that some of these are presenting with prolapse, so you can see reactive changes in the surface epithelium as well. Now we'll move on to Nabothian cysts. These are frequently encountered at the cervical transformation zone and are large fluid-filled spaces lined by endocervical epithelium. The lining cells show normal-appearing endocervical epithelium, and frequently the cystic contents of the Nabothian cyst can contain multinucleated giant cells and inflammatory cells. Another important thing to note on histologic section, so when these cells show up on pap smear, you know what you're looking at. Now we'll move on to cover tunnel clusters. This is an example of tunnel clusters here with multiple rounded lobulated endocervical glands. This is a common benign finding in usually in resection specimens. The lining of these glands show flat to cuboidal cells with benign features. So now we'll cover microglandular hyperplasia, or some people call it microglandular change. This is a very low power view of microglandular change. You can see crowded nuclei, and another common feature are the dilated glandular spaces with inflammatory cells. This is a higher power view. You can see some of the cells have subnuclear vacuolization, still with apical cytoplasm and nice rounded nuclei, but overall a denser glandular concentration than normal endocervical epithelium. But you can see at higher power, these have low to absent nuclear atypia and no mitotic figures. Why is this important? Well, it's important to recognize because there are some endometrial cancers which show features, and I've put one in the bottom left-hand corner there, of microglandular hyperplasia. And in older patients, you should make this diagnosis with caution. Microglandular hyperplasia is a change that's normally associated with younger patients, especially those who are pregnant or on progestin therapy. Now we'll cover lobular endocervical glandular hyperplasia. which has a proliferation of endocervical glands with a lobular formation, often with pyloric metaplasia, which typically involves the upper endocervix in the superficial half of the specimen. It can occur in patients with Peutz-Jeghers syndrome, which is germline STK11 mutations. And histologically, it's characterized by a central duct with surrounding lobular proliferations of endocervical glands. You can have atypical forms of LEGH, which would show end folding, tufting, and papillae. Cytologic atypia is uncommon outside of the atypical variant. So this is a higher power view, and you can see there's in this specimen no appreciable cytologic atypia. The atypical forms of LEGH are associated in some cases with invasive non-HPV related endocervical adenocarcinoma of gastric type, which we'll talk about later in this presentation. So now we'll talk about mesonephric remnants and hyperplasia. These are embryonic remnants and proliferations of the mesonephric duct, which are normally located deep within the cervical stroma at the lateral aspect, so at about 3 and 9 o'clock. Histologically, remnants are characterized by simple tubules lined by cuboidal cells with bland nuclei and intraluminal, centrally located eosinophilic secretions. Whereas hyperplasia shows increased glandular density either in a lobular or ductal pattern. Now we'll cover area-stellar reaction of the uterine cervix. So this is a benign change in glands characterized by glandular tufting with eosinophilic or cleared cytoplasm and nuclear enlargement. It's associated with pregnancy, gestational trophoblastic disease, and progestin therapy. In situ forms of carcinoma, of adenocarcinoma of the endocervix can be within the differential diagnosis. However, area-stellar reactions should show little to no mitotic activity and very rare apoptotic debris. It's important to distinguish from clear cell carcinoma, which can occur not only in the uterine corpus, but also in the endocervix, which we'll discuss later in the presentation. Now we'll cover tuboendometrioid metaplasia. So this is an example of tuboendometrioid metaplasia where you can see some rounding up of those nuclei with punctate nucleoli, and importantly, ciliated metaplasia of the surface. And this is an example where the cells are not only ciliated, but also somewhat pseudostratified. So now we'll cover adenocarcinoma of the uterine cervix. This is an area in the 2020 WHO which has somewhat changed in terms of classification and organization. So this chart helps to lay out the primary determinant of classification of adenocarcinomas of the uterine cervix is HPV status. So on the left-hand side, you can see the HPV positive tumors. On the right-hand side, the HPV negative tumors. So the HPV positive tumors are going to be the bulk of the adenocarcinomas of the uterine cervix, whereas the HPV negative are going to tend to be more rare. The HPV positive have in situ and invasive forms. So do the HPV negative, especially that gastric type of in situ versus invasive. And then there are other special types of non-HPV related adenocarcinoma, including clear cell and mesonephric types. So we'll cover all of these in more detail. But as we go through, I will reuse this schematic to march through each of the different types to try to assist learners in keeping these separate and where they fit. Now we'll briefly talk about an overview of adenocarcinoma of the uterine cervix, but the primary goal of this part of the lecture is to familiarize you with histologic features. But I did think it was important to touch upon a few salient points about this tumor, or these tumors, I should say. So studies have shown a clear distinction in outcomes for cervical cancer based on HPV status. This is a paper from 2019, which shows in the red line the HPV-associated tumors versus the non-HPV-associated tumors. So the overall trend is that in terms of overall disease-free and progression-free survival, HPV-associated adenocarcinoma those patients do tend to do better. Overall, cervical cancer remains a very common malignancy worldwide, though keep in mind that this is all types of cervical cancer, and adenocarcinoma of the uterine cervix is by far the less common than its more common counterpart, squamous cell carcinoma. But nonetheless, you can see here in terms of worldwide data, it's the fourth most common tumor in women, in female patients worldwide. This map shows the vast differences in incidence of cervical cancer in different parts of the globe. This is important. So the darker the color, the more cancer burden those countries experience. And this disparate distribution has many causes, but it is interesting to note, especially as I practice pathology, certainly in a country where it is not as common as in some other parts of the world. Important to remember. So in the United States in particular, the overall incidence of cervical cancer is decreasing. This is a chart from the Surveillance Epidemiology and End Results Program, or SEER, which shows the estimated distribution for 2020. And you can see this is data since 1992, and the overall incidence is going down. Although, the death rate that's an interesting statistic that doesn't seem to be changing quite as much. Okay, and then specifically to address adenocarcinomas of the uterine cervix, it's far less common than squamous cells. So you can see the squamous cells are the black bars on the graph. Adenocarcinomas are gray, and then adenosquamous carcinomas are that intermediate color. But you can see across age groups on the bottom, so it starts at 20-year-olds and goes to 85 and plus, that adenocarcinomas are far less common in in every single age group than squamous cell carcinoma. Additionally, relative incidence of adenocarcinomas has increased in the United States due to relative decrease in squamous cell carcinoma due to successful screening with cervical cytology. Squamous cell carcinomas are easier to detect via cervical cytology. Adenocarcinomas are harder to detect for multiple reasons, one of which being they are usually higher up in the cervical canal and harder to sample. This chart also highlights another fact about cervical cancer in the United States, which is the disproportionate incidence rates of cervical cancer and death from cancer in Black, Hispanic, and Native populations. So that's important to highlight, although it's beyond the scope of this lecture to really get into why that's happening. But now we'll move on to light microscopic features of adenocarcinoma of the uterine cervix. So we'll start back with this chart from before. And first we will cover HPV-associated adenocarcinoma in situ of the uterine cervix. So these lesions, or AIS, are frequently associated with high-grade squamous intraepithelial lesions, or CIN2-3, both on cervical cytology and in histologic sections. Most cases are associated with either types HPV 16 or 18. And by definition, these lesions do not go beyond the basement membrane. And the cardinal cytologic features include pseudostratification, which is easy to see on this one. Another helpful feature of adenocarcinoma in situ, at least in my mind, is that it stops and starts. So you can see on the right-hand portion of the screen, the more normal appearing glandular endocervical cells, and it abruptly transitions to the dysplastic epithelium. That's a common thing I find with AIS. And then, these are also common. Another common feature are the apical or floating mitotic figures, and then you can see some apoptotic debris as well. And this next image shows some more of those apical or floating mitoses. They're actually out in the mucin away from the nucleus. Another helpful feature is the coarse nuclear chromatin, which I also find helpful on Cytologic preparations, you can see the coarse nuclear chromatin here. This was a specimen which was read as suspicious for AIS, and the patient did end up having AIS. And this is an important image as well, because AIS is not only found in nicely oriented histologic sections, but this was an endocervical curettage, which you can see on the bottom portion of the screen, more normal appearing endocervical glandular cells, and the AIS cells at the top. So these lesions can be somewhat subtle. This is an example of a special kind of in situ lesion, glandular in situ lesion known as stratified mucin-producing intraepithelial lesion, which I think does a very nice job of describing itself in the name. It's also known as SMILE. You can see there are multiple floating mitotic figures and all the apoptotic debris as well. So now we'll move on to adenocarcinomas of the uterine cervix here. So we're still in that HPV-associated or left-hand side of the chart. The HPV-associated carcinomas can show one of three patterns of invasion, and these have been tied to likelihood of lymph node involvement, and in most studies, pattern C tumors show a trend towards worse prognosis, but this is an area of ongoing study. I thought it was helpful to make this chart for learners who are approaching this topic. This is a relatively new concept. It's not put in pathologic reports by all practicing pathologists at this point, but it is becoming more common and more widely used, so I thought it would be helpful to approach the HPV-associated tumors from this vantage point. The general idea being that as you go from pattern A to C, pattern A resembles more normal endocervical glands. They maintain this similar shape. They can have cribriforming. They shouldn't have a lot of solid growth, and they don't have LVI. And then pattern B are invasive foci arising from pattern A tumors, or they can have glands interspersed between pattern A glands, and they can have LVI in some cases. Whereas pattern C will have more of a diffusely infiltrated pattern, abundant desmoplastic response, irregular angulated glands. It can have solid growth, be poorly differentiated, or have a micropapillary growth pattern. So as you go from A to C, they tend to kind of get worse as you go in terms of aggressive sort of appearing features. So we'll start with pattern A. And some of these images are taken, as I've noted here at the bottom, from this website that is publicly available, and I will put a link to it at the bottom of the video. You can go here and actually go through these cases. Some of them are in the form of almost a quiz, so you can quiz yourself on these invasion patterns. But I found that they were very helpful, and I used some of them throughout the presentation. But this is a pattern A, so you can see that this adenocarcinoma is maintaining the overall shape of an endocervical gland. It can doesn't have a lot of solid growth and not a lot of cribriforming. The cytologic features of these tumors are similar to those noted in AIS, with apical mitoses, coarse chromatin, pseudostratification, and apoptosis. And P16 should be diffusely or block type positive in these lesions, which can be helpful with lesions in the differential diagnosis, including endometrioid adenocarcinoma, which sometimes can overlap morphologically with endocervical adenocarcinoma. So now we'll move on to pattern B, in which these invasive foci you can see here are arising from pattern A glands but causing a desmoplastic reaction. The invasive glands may also be interspersed between the glands, which some of them almost appear to be here. This is a higher power view showing some of the inflammation associated with those invasive foci. And in pattern C, which is here, you can see that the glands show a diffuse infiltrative pattern with abundant desmoplastic response. The infiltrative glands often show irregular or angulated forms, as they do here. And some tumors, not here, but like I mentioned earlier, can have solid growth patterns. This is an example of a case with a micropapillary growth pattern. And now to go to the special types of invasive endocervical adenocarcinoma, you can have mucinous types with intestinal differentiation. You can note the presence of goblet cells here. And this is an example of a special type of invasive carcinoma, stratified mucin-producing carcinoma, thought to arise from those smile in situ lesions that we discussed above. And these are characterized by the solid nests embedded in inflamed stroma, and you see mucin-bearing cells within those invasive nests. So now we'll go over to the other side of the chart, the HPV-negative tumors, and we'll start with HPV-independent adenocarcinoma in situ. Gastric type differentiation is characteristic of these lesions. The cells show columnar to cuboidal morphology and can have eosinophilic or vacuolated cytoplasm, which colonizes pre-existing endocervical glands. They likely exist on a spectrum with those lobular endocervical hyperplasia lesions we discussed up in the benign portion of this lecture. Mitoses are usually rare, and nuclear atypia ranges from mild to moderate and sometimes severe, and you can have focal cribriforming in these lesions. So now we'll discuss the HPV-independent gastric type adenocarcinomas of the uterine cervix. These tumors were formerly known as minimal deviation adenocarcinoma or adenoma malignum. That terminology is no longer encouraged. They account for a minority of cervical adenocarcinomas worldwide, about 10 to 15%, with higher incidence in some countries like Japan. The tumors tend to be large, and if they diffusely involve the uterine cervix, they can cause something called barrel cervix. And in this photo, you can see a characteristic feature, which is deeply infiltrative glands with haphazard morphology. Some cases show low-grade cytomorphologic features reminiscent of the in situ lesion we just discussed. The cells have columnar to cuboidal appearance with distinct cell borders, and mitotic figures are rare. Desmoplasia is not prominent. Other cases show more haphazard infiltrative glands. Note the distinct morphologic difference with the usual type, HPV-associated endocervical adenocarcinomas. This is a higher power view with the morphologic features of this carcinoma, including punctate nucleoli. Note the prominent but small nucleoli. Another helpful feature for these carcinomas is negativity for estrogen and progesterone receptors. Lymph vascular invasion occurs in about half of these cases. So now we'll go to the HPV-independent adenocarcinoma clear cell type. These tumors resemble microscopically their counterparts in the uterine cervix. The clear cell carcinomas associated with intrauterine DES exposure occur in the ectocervix and happen in younger patients around 20 years of age, while sporadic lesions occur in the endocervix in middle-aged patients. The tumors can show varied features, just like clear cell carcinoma of the uterine corpus, but in general show glandular spaces, as you note here, with a single layer of cuboidal cells. And they show this characteristic hobnail morphology with cleared to eosinophilic cytoplasm. So now we'll cover the HPV-independent adenocarcinoma of mesonephric type. These are thought to arise from mesonephric remnants and can show a spectrum of histologic changes, including ductal or sort of more endometrioid-like or a tubular pattern. A characteristic finding are these dense eosinophilic luminal secretions, similar to that noted in mesonephric remnants, actually. And these tumors can show overlap with many other lesions, for example, endometrioid adenocarcinoma. A helpful feature can be expression of GATA3 in some tumors and negativity for estrogen receptor, and P16 should show non-diffuse staining. So now we'll cover the last category, which is other adenocarcinomas of the uterine cervix, specifically endometrioid subtype. Has similar morphology to that noted in the uterine corpus, but one must exclude mucin-depleted forms of usual type HPV-associated endocervical adenocarcinoma. And a helpful feature is that P16 should show non-diffuse staining as noted here. So that is all that I have, and here are some references that I found helpful, and these will also be posted down below the video with a link to more resources, including a handout which covers salient features of what I've discussed here, as well as an evaluation, which I would appreciate it if you would fill out. I always respond to and take into account all of your feedback. So thank you so much.